Well, thank you everyone for joining. We appreciate you taking time out of your day to join us here to discuss hand hygiene monitoring. My name is Cindy S. Redcar. I am with Intelligent Observation, and I am joined by Bridget McEnroe from Doylestown Health. If you could go to the next slide, please. Just a few quick introductions and agenda items. So we will introduce ourselves. We do have everyone muted for this webinar. So if you have any questions, please place them into the chat. We will hold questions till the end. We will review any questions that are placed in there at the end of the sections. We plan on doing a quick overview of intelligent observation and the overall function of the system. And then we will jump into Bridget and Doylestown Health implementation, findings, lessons learned, things like that. You can go ahead and go to the next slide. Again, my name is Cindy S. Redcar. I am the Vice President of Sales and Marketing with Intelligent Observation. I have been a nurse for 25 years. My background was critical care and emergency medicine. I have spent about the last 19 years in the healthcare technology space in the sales end of the world. And Bridget, I'll let you introduce yourself.
Hi, good afternoon, everyone. I am Bridget McEnroe, and I'm the Director of Infection Prevention at Doylestown Hospital. I've been in nursing for close to 42 years. Crazy to believe that. And most of over my 40 years has been equally divided between perioperative nursing with the last 20 years in infection prevention. I've been part of Doylestown Health for the past almost close to 7 years. And in this role here the whole full 7 years. And I am really excited to be here with all of you today to be able to just share with you our experience with the IO system. So thank you.
Thank you. Okay, next slide. So I will start off by telling you a little bit about intelligent observation. We have been around since 2019. Here's what we know today about hand hygiene. So visual observation is still currently the gold standard, what we see in hospitals today. That comes with its own set of challenges. Obviously, visual observation captures about 1% of the overall hand hygiene opportunities in a hospital in a given day. In addition to that, there are things like the negative Hawthorne effect, where people tend to do the right thing when they know they're being watched. And one thing in particular I do hear from a lot of infection control practitioners is that they do need assistance with capturing all of their hand hygiene observations. With that, the data tends to become more subjective in nature. For example, if you're using nursing directors or nurse managers to do observations, they tend to do the observations when they see the hand hygiene completed. So the data becomes more subjective, not as objective as setting aside time to watch hand hygiene in a specified time period. Next slide, please. So hand hygiene has been around for about 10 years. There's been obvious barriers to the adoption of the technology in the healthcare space, those being inconsistent and inaccurate data. The systems are highly complex to use. They require integration with Wi-Fi systems, and overall just expensive to adopt the technology. So with hand hygiene monitoring technology, we've really taken these three barriers that we were seeing and used them as the cornerstone for developing the technology that we have here today. Next slide, please. We use something called near-field magnetic induction technology. Our founder and CEO actually spent 3 years patenting this technology over from the automotive space to the healthcare space for this use case for hand hygiene monitoring. We have the ability to adjust the size and location of the area in which we monitor. So we have the ability to have centimeter level accuracy to our technology. Think of it like this technology is actually in push start vehicles. So again, we patented this technology over to the healthcare space for this particular use case, and we are the only vendor to use this technology today. Next slide, please. This technology has allowed us to partner with over 70 hospitals in the US today. Next slide. NFMI technology versus RFID. So again, this technology gives us the ability to adjust the size and location of the technology and gives us the ability for the centimeter level detection capabilities. The design of RFID and Bluetooth technology mechanically cannot achieve that. So again, we have the centimeter level accuracy. They have a plus or minus 3 meter level of accuracy detection. We do have the ability to transmit our signal through liquids. Why is that important? When you're wearing a device on a human body, the human body is made up of 60% liquids. That signal can get absorbed and not properly transmit. We also do not require line of sight for our signal to transmit, so we do work under PPE as well. We are a very low power technology. A lot of comments I hear back from infection control practitioners is if a device needs to be plugged in or charged on a regular basis, it makes it very challenging for them to use the technology. Our technology does not require charging. We do have a battery powered system. So in patient rooms, we do not require any type of power to be plugged in. So um, a lot of systems out there with that do require power end up getting unplugged and then the signals get disrupted, et cetera. So again, we are a battery powered technology as well. And we believe that we are among the most affordable system in the healthcare space. Are not required to purchase expensive hardware from us upfront. We are a subscription based service. Next slide. Benefits of using our system. So we are the only system that can accurately measure both bed zone and room in and room out. We do have the ability to provide both group level and individual level reporting. We are soap agnostic, so that means it does not matter to us what brand of soap or sanitizer you use. We can work with anything that you are currently using. We do capture hand washing duration. This is important when you have isolation rooms or rooms perhaps with C-diff where hand washing is a requirement for providing care to that patient. And we are a fully standalone system in that we do not integrate with your Wi-Fi whatsoever. And again, we believe we are among the most affordable system in the healthcare space. Next slide. How the system works, as you can see in step one, the caregiver is wearing a smart badge, and that smart badge is actually an ID badge holder. So a lot of our customers tend to make that part of the uniform. The caregiver will wear that badge. That badge will communicate with what you're seeing in step two. Step two shows beacons above the soap dispensers, perhaps a beacon above the door. If you're measuring bed zone, you might see a beacon above the bed. That data then communicates to other devices that are placed in and around the patient care area, which uploads the data to the cloud and then produces the data that you're seeing in step three, which populates your dashboard. Next slide. This is an example of our dashboard in the upper left-hand corner. The dashboard is, you have the ability to adjust the data as you want to look at it. So you can change date, time, you can change it by role, you can change it by unit, and you have the ability to look at overall hand hygiene in addition to hand washing compliance as well. In addition to individual level data, we do provide room level data. This is important for perhaps isolation rooms. You have the ability to take a look at that room at a glance. And in the bottom right-hand corner is one of our infection tracing tools. This one happens to be for C. diff. This gives you the ability to monitor if hand washing is occurring in those rooms. And in the event you do have a missed hand hygiene compliance event, you do have the ability to do adverse event tracing. You can look back, see other patients that were potentially exposed in the event that hand washing was not utilized. Next slide, please. This technology has, allowed us over the last 3 years to really do a lot of case studies with our customers. On average, we see an increase of about 30% in hand hygiene compliance. Bridget's going to go over Doylestown's findings specifically here in a few minutes. But as I mentioned, on average, we see about a 30% increase in overall hand hygiene compliance in our facilities. Next slide. We are an annual subscription-based service, so we do have an all-inclusive fee. Our all-inclusive fee does include installation of all the hardware. It includes badges for all of your frontline healthcare staff. We do have a dedicated account manager that gets partnered along with you for the duration of your subscription. This individual will help you target education, do ongoing training. They will also help you manage, well, they will manage the hardware and devices for your facility, and monitor if you're having any issues with any of your devices as they visit your facilities. They do, and the fee does include customized dashboards as well, and push reports that we can set up for you. And then we also complete an annual technology refresh as a part of the subscription service as well. And again, we believe we are among the lowest price in the market when it comes to hand hygiene monitoring. If you want specific data for your facility, please feel free to drop your name and your email into the chat, and we will follow up with you individually. With that, I'm going to turn it over to Bridget and have her take it from here.
Thank you. Thank you, Cynthia. Next slide, please. All right. So good afternoon, everyone. It's hard to believe, but it has been close to 2 centuries since Dr. Ignaz Semmelweis identified that the simplest way to prevent spreading infection from patient to patient was simply by performing hand hygiene. Even prior to his discovery, the surgical scrub was adopted in the early 1800s. Despite these discoveries, it took until the 1980s before the CDC officially incorporated hand hygiene into routine American healthcare with the release of the first national hand hygiene guidelines. So today, hand hygiene compliance, despite the 1980s having that release of the hand hygiene guidelines, hand hygiene compliance in healthcare workers continues to average somewhere between 40 and 60%. Although education, training, leadership, and behavioral incentives are important components of a hand hygiene program, the Joint Commission, World Health Organization, and the CDC additionally recommends hospitals implementing monitoring systems and practices to enforce hand hygiene and to be able to provide just-in-time feedback. Next slide, please. So once considered, as Cynthia has mentioned, and once considered the gold standard was direct observation collection of hand hygiene compliance. But this way is limited, it's costly, and it's very subjective. Imagine all of you have experienced what we experienced here at Doylestown is finding and training staff to not only perform the hand hygiene observations, but to feel comfortable and empowered enough to provide feedback is time-consuming, costly, and personnel intensive. More importantly, validity is greatly limited by the behavior of the healthcare workers when they identify who the direct observers are, or as I like to call them, secret shoppers. Monitoring the use of hand hygiene products was another way that was introduced as an option, but it was quickly proven ineffective and inaccurate. The type of monitoring doesn't measure denominator or total potential of opportunities. And more recently, the electronic surveillance hand hygiene system was brought into the scheme of collecting data. And after installation and staff education, captures hand hygiene moments with the patient within the patient care environment and compliance. It is objective practice for health hygiene collection, allowing IPs and managers additional time to perform just-in-time education, coaching, and to identify barriers which may inhibit the hand hygiene success. Next slide, please. Thank you. So why transition to an electronic surveillance system? Why we decided to make this transition is we wanted an objective way to capture hand hygiene data at all opportunities of our associates, and we wanted it to capture enough observations to give us meaningful data. When you stop and you think at some point there are 10 observations in a week, sometimes 10 observations in a month were what we were receiving. 2 non-compliant people gives you an 80%. 5 gives you a 50%. And so truly, when you want to look at meaningful data, the more data you can capture, the better you're going to know what your practice is. Next slide, please. So why intelligent observation? I will share with you that over the course of my last 15 years of being in a infection prevention leadership role, I had the opportunity to review many of the health hygiene surveillance systems. And there was never one that I was truly sold on, for a multitude of reasons. It wasn't that any of them were not good systems, but it just didn't meet the needs of the organization where I was currently employed at. YIO, this system, like Cynthia shared, it does not need access to your computer system at all. And that's huge. In this day of cyber attacks, to be able to have a system that you could go to your chief IT officer and say, I found a system that does not tap into our computer system right away, was a win, and very supportive of him. The results are going to be objectively collected versus subjectively. When you're doing direct observation, a lot of times you're getting our healthcare or your hand hygiene when your associates are entering a patient care area and room or exiting that area or room. But what currently happens inside the room is not always picked up. So this system, when you do an electronic surveillance system, there's no subjectivity in this at all. The observations are collected by a system, and each associate will receive their individual badge, which was another plus for me. Some of the systems that I had observed in the past, badges were shared, which meant that when you came on to work in the morning, you literally signed out a sensor, placed it on, wore it throughout the day, and then had to return it. With the IO system, everyone gets their own individual sensor badge. It allows you to also measure soap and water compliance. Identification of the rooms with poor compliance is huge. And not only for the C-diff rooms, but I think one of the biggest things that we've identified here at the hospital is having this available to us. We've noticed that sometimes the rooms that are the farthest away from the nurses' stations are the rooms that might not have the highest compliance. And that is valuable information, because then you could go up and work with the staff to say, how can we make this better for you? How can we make it easier? And we also can work our EVS team and state, what happens by the time you get to the room that truly is the furthest away on the patient care unit. You identify that maybe hand hygiene, the solution needs to be replaced. You go on your way, you go back, you're pulled to other directions, and there's just a breakdown in systems. So this has always been really valuable for us to identify some of the reasons why, other than the fact of knowing which rooms we do have to focus on. The weekly push reports are amazing. And the weekly push report is a report that we receive. We receive it usually Monday afternoon, late Monday afternoon, and it gives us data not only for the past week's performance, but we get the data for this past 7 days, 30 days, and 90 days. And I'll be showing you how we share this with our management team later on in the presentation. But it allows us to see overall compliance units and by unit and discipline, and are we performing better? Who do we need to focus on? Are there specific associates we need to focus on? And what was happening in the week previous that could have decreased or increased some of our hand hygiene compliance? Next slide, please. So how did we onboard and how did we initiate the system? I will share with you that our account manager was amazing with helping us to educate. Education on this system is huge. On any electronic system, you need to sit down we sat down with our account manager and we developed a plan. First of all, who were we going to roll it out to? We weren't going to roll it out to everyone in the hospital. At this point, we made the decision to focus on different disciplines, those that had the most direct patient care. So we did do our patient care associates, which were our RNs, PCTs, and unit clerks on all of our patient care units. We worked through issues that they had. I mean, I think some of the biggest issues were making sure that they understood this was not Big Brother watching them, but that once they went into the patient room and were away from the sensors, there was no way for us to know where else they were in the hospital, unless they were working on another patient care unit. But just to go to the cafeteria, for them to go wherever they were going, this was not following them. It was picking up the data where the sensors were to show that they were performing hand hygiene. Our account manager became, I will tell you, the point person for a lot of our staff and associates, because they are so dedicated to the system and to you as an organization that they provided a lot of the onboarding education and they answered a lot of the questions, to the point when my team and I would go up to see how things were going during the rollout. They actually asked if we could call our account manager because they had a question. So we did have to share with them that at this point, we would probably be able to take over answering their questions. But from there, we decided to onboard our rehab team. And our rehab team now, so years ago, patients used to go to physical therapy for rehab. Now we do everything in the patient care units and in the patient care rooms. Rehab spends a lot of time with the patients, almost as much as the nurses and the PCTs. They were our second group that we onboarded. And then recently, over the last 7 months, we onboarded our hospitalists. These are our internists. These are our physicians that see all of our patients on our acute care and in some of our critical care areas once they have been admitted. And then our fourth group was our ID physicians. They're our newly onboarded group of physicians. And then we're moving forward this year to starting to add additional physician groups. Next slide, please. So who are we not onboarding? Just so everyone is aware, is we had made the choice not to onboard procedural areas at this time. Those are our operating rooms, our cath lab procedure areas. We're still doing the manual collecting data, and they're still submitting it to my department, and we do produce the same sort of graphs and give them results that we always have in the past. But the reason the decision was made not to onboard these areas is because this system, they're very hands-on. The IO, they are a very hands-on organization. So when they come in to check the sensors, they come in to just see how everything's doing. They do walkthroughs with us to make sure all equipment is up and running correctly. You don't want them going in and out of your peri-op or your procedural areas during the day when procedures are going on. And so that was the decision we made. This was not at this point, we were going to leave them out of the group and just onboard every other area. Next slide. So I do want to share with you. So we had a 22% increase in hospital-wide hand hygiene. If you look at where we started at a 37%. And I will also be showing you slides over the next couple slides that break it down by patient care unit. So just remember, and it's very important to remember, we were at 37% when this system was installed. Using direct observation, the hospital thought they were somewhere around 80 to 90%. And that's once again, just showing you the importance of having objective data versus subjective data. The data that was being capturing going in and out of patient rooms, it was quickly identified who these observers were. So it was passed around. I literally found out from a nurse that when I would come on the patient care unit, they would send a tiger text to everyone on the unit that I was there. Everyone knew to make sure that they did hand hygiene, that their PPE was pristine, that everything was truly what it should be, what I would be looking for. Removing that subjectivity and removing having this objective system has truly given us a true idea of not only where our hand hygiene percent is, but where we need to focus on and what areas we need to work through. Next slide, please. So this is our critical care. And the reason that I am linking, I want to show you our critical care area and remind you, this is a month ago now. So this data was from a month ago, because this is more not for you to focus on the data, but for what we send out. We can actually get this data every Monday from those push reports, change numbers in our Excel system, and be able to get this out to every manager, director, and and any senior leadership. If you look at the hospital data from the 37 or 39% up to 56%, some of you may be being like, oh my gosh, they're only still at 56%. I do want to remind all of you that within the last 7 months, we onboarded our hospitalist group. They have required a lot of education, a lot of patience. We are still educating and working with them. And they're starting to improve. Themselves are starting to improve to be some of our top performers. The IO, our account managers, were extremely helpful in coming out and speaking with our hospitalists, working through the system with them. So one thing, for example, that is something that I think everyone has to consider with specific groups. With our hospitalists, one thing we identified, when you use the system and you go into a patient room and you perform hand hygiene, it's the expectation that most of the physicians are going to sit in the charting area and chart. In that charting area is another, I call it, much to my account managers, I think, dismay, the white box and the black box. But anyway, the white box is more of a sensor that collects data and sends it up to the IO system cloud. What we identified by talking with the hospitalists, not all of them chart on the patient care units. So if they were seeing patients on a patient care unit and quickly bypassing where that box was to pick up the data to send to the cloud, they were being marked as non-compliant and thus giving us a false low percentage of hand hygiene rates. Once again, very easy. What we did is the data will stay on their sensor, and I apologize, I don't have mine on, but the data stays on their sensor. So when they go to their office space, we actually put the white box and the black box right in their office space. That way they can have the data go to their office to chart. The data automatically gets sent to the one sensor and then goes on to the cloud. And in the past month, we have started seeing an increase to being up to the point that some of our hospitals are running about a 96% compliance. Once again, if anyone has any questions or would like to see any of my newer information, you have to remember these slides were placed together, which is why I'm using data from about a month ago. But I'm more than happy to share anything or any new data that we have. I will share with you, we had decided as a hospital to make our compliance 70%, especially in our critical care. And you might think, why 70%? Why not 100%? Once again, it's for a multitude of reasons. And one of the biggest reasons is emergent. If there's an emergency going on and then this nursing staff needs to get into that patient room, they may not do hand hygiene. And I think we all accept that and realize that the first thing they need to think of is the patient. 70%, you may say, why that 30%? There may be a time that they are rushing into a patient room. Patients might be trying to get out of bed. They do a flyby, which I'll talk with you a little bit about later, so that the data might not be captured. And we'll talk about that a little bit later. So anyway, that was a decision we made here as an organization to try to get our compliance to about a 70%. If you look at our IMU and our IVU are step-down units, and then our ICU and CVICU are critical care. If you look at where they started and where they got to, that's way more than a 36% jump with where they are. And to this, our CVICU last week was up about 78% compliance. Our ICU has gone back up to closer to 70%, as well as our IMU and IVUs have been much closer to 70%. Our EDs, and I apologize right now, I'm kind of blocked by the ED, but ED is going from 28% and almost doubling theirs is significant for that group. We've been working really hard with them to do their hand hygiene to make sure that their badges are on appropriately. And I think their biggest downfall is they wear their badge. We made the badge part of our hand hygiene policy. So wearing their badge is very similar to wearing a name badge. It is a requirement of the hospital and its policy. They will wear it daily. And then what happens is they say sometimes they are going in patients' rooms to stock the rooms. And my thing is just get in the habit of doing hand hygiene. You should do it in and out, whether a patient's in there or not, just to make sure you we start seeing a true percent of what's happening in our ED. Next slide. So I want to focus, though, on our critical care and how and what we are feeling truly has made an impact. And these, if you see, we all know that we get an expected number of infections, especially device-related infections, and then we report what is observed. So what we have done, we put the graph together, and this was a graph that I wanted to show our board about how the IO system is truly helping us to decrease our infection rate. So our first quarter of 2022, we in our critical care unit had about 3 catheter-associated urinary tract infections. We put the system in March. So the first quarter, the end of the first quarter is when we implemented the hand hygiene system. And second quarter, we had none, but third quarter, we were down 1. And then as hand hygiene started to increase, the red line is our hand hygiene compliance in our critical care. So as our hand hygiene began to increase, we started to see a decrease in infections and a decrease in catheter-associated urinary tract infections. And I know with my most recent meeting with my infection preventionist, they shared that nothing truly has changed except that we adopted the hand hygiene system. So with the hand hygiene going up and them manipulating urinary catheters, it's truly, we're starting to see our numbers drop. I do want to share that the last time our ICU had a catheter-associated urinary tract infection was in July of 2023. So we are well over 200 days. Actually, as a hospital, we are well over 200 days since our last catheter-associated urinary tract infection. Next slide, please. These are central line bloodstream infections. Once again, orange is expected, blue is what we identified. As you see hand hygiene rising, you start seeing us have none or stabilizing with our central line infections. And I do want to share with you that the first quarter infection was actually in one of our step down, but the third quarter infection was from a line that was put in one of our procedural areas, but by definition from the NHSN, met the definition of infection being attributed to one of the critical care units. Next slide, please. And C-diff. We've had a 48% reduction in C-diff infections in 2023 compared to what CMS has predicted. And one thing that everyone, I think, can agree on this call, because it was talked about and there was research done, was we started seeing a decrease of C-diff during COVID. And once the pandemic started lifting, C-diff cases started creeping up again. And then once we had the hand hygiene system put in and we started to see an increase in hand hygiene, we started seeing a decrease and we started stabilizing, but we have always been maintaining below what was expected numbers. And next slide, please. So positives. I've shared some of these positives already with all of you, but just very quickly, the push reports are huge because that allows us to give real-time data to our patient care units. The expectation is those graphs are displayed in the patient care units. It's always good. We have an acute care, critical care graph, and we have a hospital-wide. I think we can all once again agree it's always good to have a little bit of healthy competition. Daily dashboard checks. This is something you saw the dashboard. Cynthia showed you that dashboard, but something she may not have mentioned is that dashboard is updated periodically throughout the day. So, you know, if I am focused on someone and I know they're working, they worked, or I'm really concerned, or even myself, if I'm out on the patient care units and want to see my own compliance, I wait a day usually, but I could go in, and as long as you have 10 observations within that 24-hour period, I can identify what my compliance was on a daily basis. Unit-based and associate results are also, that's something that we can feed back. Just every unit manager, not only do they get their unit results, but they get their individual associates or employee results of how they did that week and how they've done over the 30 and 90-day comparison. It holds everyone accountable. They know that this system is there. They know the expectation from our hand hygiene policy is that they will be wearing their sensors. And we can review the soap and water compliance also. It shows that they've not only were doing this, they're using soap and water, but they were using it for the appropriate amount of time. They must be at that sensor for about 20 seconds in order to get credit for using soap and water. A huge positive that I can't say enough to Cynthia and to the whole IO team is their quick and timely response. We have regular on-site visits by the account manager. We walk through every patient care unit just to make sure devices are functioning properly. We answer questions. They will come and answer questions that if we've had any difficulty at all answering a question with one of the associates or getting pushback from the associates, they will reach out to us within not days, but hours if we email them to try to assist us with how to best answer these the questions, because we want this system we want the associates to feel really comfortable that this system is showing them what they're doing. And we also want to make sure that there's no disciplinary action. And that was important. And that actually came from the company, is this shouldn't be about disciplining people. This should be identifying people that may be struggling with hand hygiene, and that we can focus on them and we can work with them. And that was evident, I think, in some of our critical care units, and also one of our acute care units I did not show. But we had an acute care unit that started out at about 26%. And within the last 3 weeks, they are averaging somewhere between 70 to 79% compliance. And it was because of the reports that we received, we were allowed to focus on individuals and really help them to succeed. Next slide. Of course, there's always going to be challenges. I think one of the biggest challenges we had in the beginning is wearing the device appropriately. So many associates, we give lanyards out. Every hospital gives lanyards so that you could put your IDs on. The problem is that the lanyard falls below your waistline. And in order the sensors capture a large amount, and I think Cynthia can go over that. But you need to wear the sensor somewhere between your waist and your neckline. So we always tell everyone, put it in your scrub pocket. You can actually put it underneath. So if I know some associates will wear a little tank top underneath, they can put it and clip it to that area underneath their scrubs. But that is really important to make sure that it's worn. And if they want to wear a lanyard, just lift the lanyard a little bit. Don't let it be below the waist. You have to address flybys. What are flybys? Or you may call them something different, but this was a really good education tool. When staff walk out of a patient care room with their hand behind them, they're not even getting enough of the hand sanitizer in their hand to perform appropriate hand hygiene. They need to make sure the time it takes to get the appropriate amount of hand sanitizer is all it takes for the system to upload with that sensor above the hand sanitizer. So it's just reminding them, if you're doing a flyby, it has nothing to do with uploading the data, but it has everything to also do to make sure that you are getting enough hand sanitizer to perform hand hygiene appropriately. Associate buy-in, and that was very quick, and I do contribute that to our account manager because he was very supportive of talking with all of the associates. And then once again, from the very beginning, and I'm more than happy to share ours, is have a process when you need to request new badges. And this is for as new associates are onboarded, as associates leave. We have a really good system that we have put together so that you can collect badges, return them, and then get new badges from the IO team. And next slide. That might be about my end. Yes, that's the end of my presentation. Anyone have any questions?
Great. Thank you, Bridget. Actually, there was one that just popped up. They were asking how you overcome resistance by leaders to implement the system. Was this something initiated by your team, or did you get it championed by someone, perhaps a physician leadership?
So actually, I had been looking I've been at Doylestown for about 6.5 years. And prior to coming here, I was looking at systems, just because it's just so costly and time consuming to try to do direct observation. So what happened, I have a very supportive CMO. I will share with you a very supportive CMO, but we reached out to Medline, and Medline had shared with us about the intelligent observation. So I set up the meeting. To be truthfully honest, I thought this was something that I approached. I set up a meeting to just say, hey, can we please hear this company out? Let's bring the company in. They have a lot of pluses, and showing the pluses. And I think one of the biggest pluses is them not having to tap into our computer system. We don't, it's just, that's huge. And so at that point, they did come out and meet with us as a team. And the more, I think, as we all sat together, we had our HR, our vice VP of HR, we had our CMO was involved, our CNO was involved, IPs was involved. And as all of us sat there and we talked about the pros and cons of not having a system, and once again, the system is not as expensive as some of the other systems that are out there, was also when we could produce numbers. So my recommendation is make sure you have your numbers, make sure you know what other systems entail, what the costs are, and then what the IO system is and what it could bring to the organization.
Great. Thank you.
Mm-hmm.
One of the other questions that I'm seeing pop up right now. So, did you have any room setup challenges with unique floor plans or unique rooms? Um, yeah. So our
Actually, this
system,
was easy. Yeah.
yeah, what I would say to that is that our system is very customizable. We
Mm-hmm.
customize it to your facility specifically. We can customize the size of the zones, things like that. So we don't encounter challenges. We do a on-site once you've decided you're going to move forward with the system, we do come on site and we will walk through the facility with you to take a look at things, placement of devices, doors, anything that could be an obstruction to the system functioning. And we come up with a plan to address that. But we have a great implementation team that does that on site with you. And the process, there was a question as well, who manages the process for assigning and management of the badges to employees and losses? I can answer that, and Bridget, you may want to chime in too, but we do the management of the assignment of the badges. So our account manager will assign all of your badges. They will pass them out to all your employees. They will do the ongoing management of that alongside of you as well. If you do have lost devices, it happens. We replace them. There's no additional charge for that as well. But Bridget, I don't know if you want to comment maybe on something with that. I'm sure you've experienced some of that as well.
Yeah, exactly. And I think, and they're very accommodating. When someone does lose a badge, they'll truly replace it with no cost. Unlike even their name badges, if they lose it more than once, they have to contribute back to making a third one. But I think so. What happens is the only thing you need to give to the IO system is you need a patient care unit and a list of all the associates. And that's very easy. Everyone has that. And that is submitted to IO, and IO takes it from there. So they will assign every badge. The badge is not only assigned to the individual associates, but they actually label a first and last name so that when the badges are delivered to the hospital, they are delivered in bags with the unit on them, and every badge that's in that bag will have a associate name on it. Now, if there have been changes, that's something that the manager does know, that there are changes in the system, and can pull out those badges so that we can return them. If there's new associates at that point, that we could get the new associates, we can get their badges onboarding by the time they're through orientation. Once again, this turnaround is quick. If we send a list, let's say we have some new associates, we have orientation twice a year. I mean, excuse me, I wish twice a month,
Sure.
but we have orientation twice a month. And we will send the list to IO. We wait till the day that they are literally physically sitting in the chair for orientation, because I'm sure you're all experienced what we're experiencing. Until you know they are physically there, they could at any time they could come in and just kind of revoke their employment. So we do make sure that they're here. But once we send those names to IO with a list of new associates, we get those badges with under a week, and we have it come. It's UPS and it's coming. Once again, they come bagged, individual units with individual names on them.
Great.
It's great.
Thank you. Another question. Have you seen any direct improvement in any of your hospital-acquired infections with correlating to the improvement of your hand hygiene compliance? And if
Yeah.
yes,
Mhm.
are you able to associate the hand hygiene compliance improvement with, with that, knowing that there's other initiatives going on alongside of, infection prevention in the hospital?
So, yes, this is like I had said earlier, we were just discussing this as a team. So this is our Joint Commission survey year. We just had consultants here at the hospital, which really allowed us to look at our practices. And also it's the beginning of the year. We're updating our effectiveness plans, our risk our assessments, our infection control plans. And looking at all the data, there's so much all IPs have put into place over the past couple of years. And we were kind of stagnant, it was especially COVID. COVID did also, the pandemic kind of hit hard in some areas, but so I was pulling our CMS data, and I just want to, I'm very proud of this, so I want to share this. When I was pulling our CMS data, our CAUTI rate, those CAUTIs that are going to be included in that, we have 2. We're expected to have close to 8 CAUTIs. The only thing truly that we have changed last year is we really started enforcing the hand hygiene with the IO system. We already have, implemented having a tag team when they're being inserted. We have a nurse-driven protocol for removal. Our IPs call on a daily basis to get those catheters out. These were not new. So none of these practices have been going on since I started here. But the one thing I think we really focused on last year was hand hygiene, the appropriateness, and just using the IO system that's holding them accountable. So in our central lines, yes, we did have 4 central line infections, but once again, we were supposed to have over 7. So we have seen a reduction in our central line, our device-related infections. And one of those device-related infections truly happened shortly after insertion, and the insertion was in a procedural area. Just definition is requiring it to be called DARS. C-diff, we're below by more than 10 than what was expected. And we have no MRSA bacteremia this year at all. And once again, we installed this, when you install the system, you are going to, everyone has to expect it's a new system, a little bit of growing pains until everybody knows how the system works. And they wear their badges routinely. And once we started seeing that in the last year, we really started seeing a decline in our infection rates.
Well, congratulations, because that's a huge
Thank you. Yeah.
accomplishment to all of you at
So proud.
Doylestown Health, for sure. Another question that popped up was 70% of hand hygiene opportunities happen once in the room. How do you measure the interaction within the room with the devices, patients, visitors, workstations, et cetera? I can certainly take that one. Again, with our technology and the ability to hone in on different size and location of zones, we are the only system out there that can accurately measure bed zone. So think of it like a mosquito net being tossed over the top of a bed. When that caregiver enters that zone, have they completed their hand hygiene or not? And I can definitely go into further detail if you're interested. Please put your name in the chat. We're happy to set up a one-on-one demonstration so that you can see exactly how that works. But a good question. But the ability of the technology to really zone in on a specific area gives us the ability to measure those interactions within the patient room. So a lot of times customers will say, well, we have semi-private rooms.
Mhm.
The other technologies out there can measure room in, room out. That doesn't tell you, does the nurse wash her hand between bed one and bed two? With our technology, we can tell you that. And we're able to accurately measure that as well. So, okay, any other questions from the group? I know there's been a lot of interest for presentations, and we will follow up with everybody post, the webinar here.
Mhm.
Everyone will receive an email from us with the slide deck as well as our contact information and a few other items. You will get a recording of this as well, so you can share this with others. But definitely encourage you to reach out to us or plug
Mhm.
your name in if you guys are interested in a one-on-one demonstration. I would also throw out there that Bridget is always more than willing to have
Mhm.
conversations on the side with customers as well, and we thank her for that. And we have, thoroughly enjoyed working with you and look forward to seeing continued results. Sorry, one more question popped in. Are there any challenges with the accuracy of data or staff tricking the system? Um, you know, good question. I'll answer it, and then Bridget,
Yeah.
I'll let you answer. So
Okay.
again, we're partnered with over 70 hospitals, and these hospitals aren't 100%. They've seen an improvement of 30% on average. So if they were tricking the system, everybody would be 100%.
Mhm.
That's not the case at all. In fact, we see the ease of our system make it more people tend to adopt the technology better because it's so easy to use our system. We don't tend to get the challenges that you see out there. But Bridget, I'll let you answer if you've
Yeah.
experienced any of that as well.
Um, I will share, I think it's too much work to try
Cheat it.
to go, fake the system. Is it possible it's happening? I am sure it is, you know what I mean? But that I think with the results that we're getting, and with the healthy competition that this system has brought to Doylestown, I am really confident in saying that if anybody is trying to cheat the system, they're going to be called out on it. Because the only way to cheat the system is to take your sensor and put your sensor in front of where the soap is. Go in the room, I mean, it's too many steps to try to cheat the system. To me, there's just too many steps. It's just easier to wash your hands.
Absolutely.
Mm,
Yep. I would agree with that. That's not what we, see out there.
mm,
But you commented on healthy competition too. I
mhm,
think that that's great. Bridget mentioned this throughout her presentation is this isn't about being punitive. It's
mhm.
about, effectively making change management within the organization and celebrating the wins when they're there. And I know Bridget's done a good job with that, especially within the ICUs. So, um, I don't see any other questions unless, Seth, I know you were monitoring. Oh, trial period. I do see that. So we have done trials in the past, but all a trial really tells you is, if you're receiving the data, and we're happy to talk about trials. So if that's something you're interested in, please reach out to us. Give us your email. We can talk about that offline. So not to say that we don't do them, we do, and happy to go through that with you individually. Okay. Sorry, Seth, did you have any others that maybe we should share that I missed?
I don't think so. Hey, everybody, this is Seth Friedman. I'm the founder and CEO of Intelligent Observation. I just wanted to close with thank yous. First of all, thank you so much, Bridget, for your time in doing this and putting this together, and certainly for the partnership. I remember very well coming out and sitting at Doylestown many years ago with your team that you talked about during the presentation. I remember the conversation, and now seeing what you've done with the system is fabulous. And I'm just super appreciative, and our team is super appreciative. Thank you very much. I also wanted just to take a second and thank the Leapfrog Group.
Yeah.
We are proud members of the
Mhm.
Partners Advisory Committee, and we really relish the opportunity to work with a group like Leapfrog towards patient safety. We sometimes we get a little lost in the weeds, but this company was formed and this company exists to try to reduce healthcare acquired infections and all of the negative outcomes that are associated with these infections. And that is really the mission of this company. And that's what we drive towards and what we strive to do. And I think, in summary, if I can leave everybody that's still on the call with just one thought, it's that, when you work with intelligent observation, right, we have an aligned goal to reduce these infections. And that's how we go about doing our business, as partners with you in an effort to make an impact on patient safety. And so again, just thank you for your time and everyone's time that was here. Thank you again, Bridget. Thank you again to the Leapfrog Group. Thank you, Cindy. Really, really appreciate it.
Yes, thank you. Well, thank you, everyone. We look forward to working with all of you who have reached out. And again, if you have any questions, do not hesitate to reach out to us. We look forward to, hearing from everyone. And thank you, Leapfrog. We appreciate it.